Let's talk about liver abscess. In this video, we are going to discuss about the two types of liver abscess, the pyogenic and the amoebic liver abscess. Before studying them separately, let's have an overview of the topic. Like a patient of liver abscess presents you to the OPD with a complaints of fever with chills and rigor. He will have abdominal discomfort, pain around the right hypochondrium. On examination, you will find tender hepatomegaly as well, and jaundice may or may not be present, and other generalized features like anorexia, nausea, vomiting can also be found. Now coming to pyogenic liver abscess. First of all, we will study about the organisms responsible for it. Then we will go into the root, how does it spreads into the whole body, the route of infection. Then we will study the investigation and the management. So organisms like E. coli is the most common organism in the whole world, and if initiates us, then initiates Klebsiella, and in general with chronic granulomatous disease, it's Staph aureus. Now coming to the route of infection, the most common route is bile duct. Bile duct inflammation, known as cholangitis, is most commonly responsible for it. Then next can be through portal vein. Any appendicitis, diverticulitis can cause it. It can also spread through hepatic artery, like if a child is having chronic granulomatous disease, then through the hepatic artery it can spread. And then the one of the commonest was the local spread, like through a subdiaphragmatic abscess or a pleural effusion infected one, it can spread. And the final one, sepsis. Then live sepsis or trauma can cause. So this was the route of infection. Now coming to the investigation, you will carry out the routine investigations. In the liver function test, you will find raised ALP levels, and you will do the other investigations like USG, CCT, where you can find some localized sepsis. And to confirm the diagnosis, you will do the aspiration guided by USG and culture to prove it. And many times it can be polymicrobial. For the treatment, you will insert a pigtail catheter with systemic antibiotics. So this is all about pyogenic liver abscess. And there can be some complications as well. Like if it ruptures, then it can go into the pericardial cavity causing pericarditis. It can go into lungs causing pleural effusion, or it can spread into abdominal cavity causing peritonitis. Now coming to the next topic, amoebic liver abscess. It spreads through Entamoeba histolytica. The most common cause is poor sanitation and hygiene. It enters the body through the fecal-oral route. The cysts are ingested with the infected food and water. They release the trophozoite in the small intestine. These trophozoite create flask-shaped ulcer in the colon and the cecum. Then through those ulcers, it finds the route through the portal circulation and enters the liver. In the liver it attacks the hepatocytes, causing histolysis of the hepatocytes and rupture damage to the RBCs, producing an anchovy sauce appearance. This anchovy sauce is a sterile, odorless. On the Now you will go for the investigation. In investigation, you will do USG. In LFT, you will find raised PTINR. On aspiration, you will find a sterile fluid. Now coming to the treatment. You will give metronidazole 750 mg TDS for a few days. After that, if it's not responding to metronidazole, then you go for other treatments, which is a 10-day course of diloxanate furoate. A luminal amibicide is given, and if there is no response or if there is a secondary infection, we go for the pigtail aspiration insertion, pigtail catheter insertion. And there are some other indications also of pigtail, which is like this: if there is an impending rupture, or if it's left lobe abscess, if it's a pregnancy, as in pregnancy metronidazole is not given, or the abscess is greater than 5 centimeters, or if there is no response to the medical therapy. And the radiological resolution can take as long as 6 months. So this was all about pyogenic and amoebic liver abscess. Thank you for watching. Let's talk about now hydatid disease of liver. It is caused by Echinococcus granulosis or Echinococcus multilobularis. The dog is the definitive host and sheep is the intermediate host. And accidentally the human male ingests the embryonic eggs from the dog feces. It goes into the intestine. From there, it penetrates the portal capillaries, reaches the liver, and then creates cyst in the liver. Usually, these patients are asymptomatic, presents with hepatomegaly. On USG and CECT, you will find multiple cysts. The treatment of choice for them is albendazole. And if it's not responding, you go for percutaneous aspiration and insertion, injection, and reaspiration. We do this procedure under UST guidance, where we introduce a scolicidal agent to kill the organisms. The most common scolicidal agent is hypertonic saline. Ethanol can also be used. There are some contradictions also for the PA therapy, like if the cyst is already dead, or it's calcified, or it's impending rupture, or it's multiseptate, or it has some biliary communications. So we avoid that condition. So there we go for other procedures like liver resection or pericystectomy. So this was all about hydatid disease of liver. And also you can go look into the anatomy of that cyst. It has three layers: endocyst, ectocyst, pericyst. Thank you for watching.